Welcome to the University of Texas School of Dentistry at Houston, a recognized continuing education provider pursuant to Board Rule 22, Texas Administrative Code, and 104.2, and any subsequent amendments. In accordance with the Texas State Board of Dental Examiners Pediatric Sedation Anesthesia Course Guidelines, this 16-hour online course will provide background and didactic information that complies with the Texas Administrative Code, Title 22, Part 5, Chapter 110, Rule 110.17. The Texas State Board of Dental Examiners' mission is to protect the public by the establishment of the course with the goals of increasing training, reducing adverse sedation events, and maintain a continued oversight of sedation. The purpose of the course is to familiarize participants with the background, didactic evidence, and techniques utilized in Level 3 Pediatric Sedation Anesthesia. The online course must be completed prior to the patient treatment skills, and all must be completed within a 2-year period of beginning the board-approved program. The permit holder may not administer sedation anesthesia under a Level 2, Level 3, or Level 4 permit to a pediatric patient unless the permit holder has completed the requirements of Paragraph 1 or 2 of Rule 110.17. Successful completion of the program must include passing an evaluation to demonstrate satisfactory completion of the course requirements. The didactic education is comprised of 16 hours outlined in Rule 110.17. The rules include 108.7, Minimum Standard of Care, General, 108.8, Records of the Dentist, 110.3, Nitrous Oxide Oxygen Inhalation Sedation, 110.4, Minimal Sedation, 110.9, Anesthesia Permit Renewal, 110.13, Required Checklist for Administration of Nitrous Oxide in Levels 1, 2, 3, and 4 Sedation Anesthesia, 110.17, Sedation and Anesthesia. One must understand and be compliant with all the rules and amendments guiding the administration of the Texas sedation anesthesia patient treatments. Treatment providers must be skilled for the level of sedation permitted and for higher levels to which the patient may enter. The modules are prepared in order so that progress from the beginning is necessary to understand the subsequent modules. Welcome to the first module of Sedation and Anesthesia for Pediatric Patients. I'm Dr. Gary R. Badger, DDS MS, Professor of Pediatric Dentistry at the UT Health School of Dentistry at Houston. I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. Section Overview. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for the various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rules 110.17, Sedation Anesthesia of Pediatric Patients. This is Module 1, Pre-Anesthetic Patient Assessment for Pediatric Patients. The objectives are to complete this course. You will be able to perform a pre-anesthetic assessment or evaluation for pediatric patients. The Texas Administrative Code is listed here to help acquaint you with the information that you need to qualify for taking this online course. So be ready to comply with all of these requirements as time proceeds. The didactic hours of instruction are as follows. The pre-anesthetic patient assessment evaluation for pediatric patients, physical evaluation and medical history of pediatric patients, including obesity, limited neck mobility, micro and retrognathia, macroglossia, Mallampati score, and limited oral opening. Pediatric anatomical and physiological differences, pediatric respiratory assessment, including airway, anatomy, physiology, and management. Informed consent by parent, guardian, and/or caretaker, sedation and anesthesia pharmacology, sedation anesthesia management of pediatric patients, pediatric patient monitoring, preoperative complications and emergencies, emergency management of pediatric patients, including pediatric anesthesia equipment and resuscitation supplies, sedation anesthesia technique, sedation anesthesia record keeping, patient recovery and discharge, pediatric case selection and reference behavior scale. The 15th section is satisfactory management and completion of treatment of pediatric patients under the on-site instruction and direct supervision of a licensed dentist authorized to administer sedation anesthesia to pediatric patients. Cases are 1, include at least 3 live cases in which the permit holder is the primary sedation anesthesia provider, or 2, at least 15 cases involving pediatric patients sedated or anesthetized where no more than 7 cases are observed on live patients and at least 8 cases are performed as part of a hands-on high-fidelity sedation simulation course or program. The case study we're going to talk about initially is to acquaint you with the approach to treating patients with sedation and anesthesia. This case study involves an 8-year-old patient presents to your office several weeks, 2 months after undergoing general anesthesia for restorations and extractions of tooth number S, the lower right, first primary molar. A comprehensive dental examination is performed, including an extra-oral evaluation, intraoral evaluation, chief complaint, medical history, dental history, and a social or family history. The patient has been having pain on the lower right permanent molar region, especially when brushing. The medical history is non-contributory. The dental history includes visits to 2 oral surgeons, a general dentist, and a pediatric dentist. The patient was seen for the extraction of tooth number S, which had a large lingual cusp fracture due to undermining caries, losing the entire lingual surface, exposing a large carious lesion. The mother relates a history of visiting 2 oral surgeons who were unable to remove the affected tooth. The following general dentist was also unsuccessful using active protective stabilization, and the child was referred to a pediatric dentist for treatment. The patient was evaluated and taken to the hospital operating room for completion of multiple restorations and removal of tooth number S. You receive the patient in the reception area where she is shielding herself behind the right shoulder of her mother, while her 10-year-old sister calmly resides at the mother's left side. The mother relates the medical history and begins the history of the child being resistant to treatment at the 3 previous offices and then being taken to the OR at the last visit. The intra and extraoral evaluation was accomplished after the mother lifted the child into the dental chair as she forcefully placed both hands over her mouth and began to cry. The mother states that she doesn't want her child forced to open her mouth, and it doesn't happen, that she will just wait until she can tolerate it. She doesn't want her behavior to regress from where she is today. A glance at her mouth revealed tooth number S missing and slight lower anterior crowding, approximately 2 to 3 millimeters, and the upper lateral incisors unerupted with about 4 millimeters, 2 on each side of the centrals crowding. The mother was advised that space maintenance would be desirable to preserve the remaining space And Mom said she would not go through the banding process again as it was unsuccessful before, and Mom would watch for space loss, and if she saw any, she would return for treatment. She was shown the size of tooth number L to compare it with the right side, and it was noted that she had already lost about 3 millimeters of space with migration of tooth number T, and 19 had migrated into that space compared to tooth number L. The social history of this case reveals that the sibling sister is not the difficult one, only the patient. No other significant history otherwise. How would you handle this situation? Establishing a problem list is important to prioritize how treatment is rendered. Behavior of the patient's emotional status is one of the first items on the problem list, and behavior of the mother, emotional status, and perception of the child by the mother, limitations are expected. Untreated dental caries causing pain, is it how serious? Untreated space loss or space regaining, will this cause a malocclusion? Overall space requirements, diagnosed occlusion, overjet, overbite, facial profile, E-space, primate space, generalized spacing, caries risk level, all provide opportunities for assembling a preventive activity such as fluorides, oral home care, and diet. How would you prioritize this list? Behavior evaluations for pediatric patients is commonly evaluated using the Frankel score. The Frankel score basically says that at level 1, the patient's behavior is very bad. At level 2, not so bad. At level 3, an improvement, some cooperation. And level 4, the patient's behavior is exemplary and they're able to treat. However, those behaviors are affected by the age of the patient. And you will see at the left-hand side of the chart, patients that are 0 to 2 years of age have mild to moderate the treatment difficulties. Patients that are 3 to 4 have moderate to difficult. Patients at 3 or 4 can also be very difficult. And the behavioral ranking that you see in the center describes how that behavior would be. Patients that are 5 to 6 would go from mild to moderate difficulties, and patients 5 to 6 can also be difficult. Using this Frankel behavior scale allows one to, over a period of time, describe how the patient's behavior occurred during the dental procedure. Here, for example, is a patient who's 2 years old whose treatment needs are really severe. It's important to realize that the behavioral scale, Frankel, can help characterize this patient's behavior when they come in for dental examination. Here, for example, is a 3-year-old with a similar treatment needs, a lot of early childhood tooth decay and severe erosion of the teeth due to the use of the bottle over time. And so this is a very large challenge for a child at 3 years old when most of the teeth are going to be repaired through a restorative process. Here is a 4-year-old whose treatment needs are a little bit less, but involves a very traumatic procedure to proceed with this child and be able to take care of their needs along with a distal shoe space maintainer. So this prioritization requires long-term care. This is a 5-year-old who has had some treatment done but has receded back to some of the early caries, and there remains many more teeth that need to be treated. So we can see there's a huge spectrum of children that are 2 to 5 years of age. And here is a patient who's a little bit older at age 6, requires some treatment needs and long-term observation and treatment of this spacing that was developed as a result of early tooth loss. Level 1 sedation, which is a minimal level of sedation, this type of permit, is defined as a minimally depressed level of consciousness produced by a pharmacologic method which retains the patient's ability to independently and continuously maintain an airway and respond normally to tactile stimulation and verbal command. Nitrous oxide may be used in combination with a single enteral drug in minimal sedation cases. Other sedation levels provide for the doctor A decision to use sedation on a patient with the following documents must be in place. A preoperative checklist by administration of levels 1, 2, 3, and 4 sedation anesthesia governed by TSBDE rules, a written emergency plan, and after September 1st of 2019, permit holders may not administer sedation or anesthesia under a level 2, level 3, or level 4 permit to a pediatric patient unless a permit holder has completed a university or hospital-based residency of at least 12 months in length, completing satisfactory management of sedation anesthesia involving a pediatric patient at the highest level of permit held for the number of cases prescribed by the rule. Sedation levels, a board-approved education program that includes minimum of 16 hours of didactic training and instruction in sedation, anesthesia of pediatric patients governed by Texas State Board Dental Examiner Rule 110.17. And 3, a permit holder must pass the online jurisprudence exam once every 5 years to be licensed in the state of Texas, governed by Texas State Board of Dental Examiners Rule 110.9. Here is an example of a preoperative checklist. One can make their own checklist according to the TSBDE rules. This happens to be one that is very similar to many of them that are being used in the School of Dentistry and allows one to ensure that all parameters have been met prior to taking the child to their sedation appointment. This is the top part of it. It involves several portions of checklists which must be evaluated. Initial examination, medical history, history of hospitalization, opportunities for previous sedations and how successful were they, what the patient's behavior is, how to handle developing situations within that treatment area, and etc. So review this preoperative checklist carefully. You may wish to add other things that you prefer in your own. It's governed again by the Texas Board of Dental Examiners, and you can adjust this in any way that allows you to be much more comfortable with the list. Here is the lower part of this preoperative checklist. It involves ASA classifications, Mallampati, Brodsky evaluation, something that we will talk about later in this course, and allows you to put in some notes that tell you how you're going to respond and prioritize the list of treatments for this patient. At the bottom, there's a place for one signature, and be able to make sure that that is signed off with the parent's consent. The preoperative sedation anesthesia checklist is utilized there for the safety of the patient and being fully prepared to deliver appropriate sedation once the checklist has been completed. The pre-procedure review allows an opportunity to again utilize a checklist so that one can be ready for the sedation opportunity after the total examination and be ready along with the appropriate signatures and consent of the parents so that everything is completely answered. Here, for example, is another type of checklist which allows you to get consent from the patient and understand exactly what's going on with the patient. So both of these documents are essential to be able to provide the proper sedation environment and outcome that's needed for the patients. So read this over carefully, make sure you fully understand it. Again, this is one that you can modify for your own practice and the types of things that you wish to have on your preoperative evaluation. Pre-anesthetic patient evaluation is a really important area of clinical observation. The pre-anesthetic patient assessment and evaluation consists of the following elements: an extraoral exam. This includes a cancer palpation of the lymph nodes of the patient. Intraoral examination, where the hard and soft tissues are evaluated in their condition, their environment, what's going on there. The chief complaint, What brought that patient in for that day? Was it a regular checkup? Was it complaints of pain from discomfort or some long-lasting poor oral hygiene that's gone on with this patient? So it's important to look at the chief complaint. The medical history is really essential, and it's important that every aspect of the patient's medical history be understood by the practitioner. It allows one to see how safe it is for this patient to receive sedation, anesthesia, and if there's any question about any aspect of the medical history, it is important to get a consultation so it's fully understood what the medical history brings to the table. The dental history is equally as important because it tells us how often this patient has been seen for dental care in their history. And it's important to understand, are there circumstances where the patient has already gone to a practitioner? What was the outcome of that? Was it difficult? Did the patient tolerate it? Did the patient not tolerate it? And oftentimes there's a great deal of expectation by changing clinicians to ensure that the patient past dental history is not repeated in some cases, and in some cases we want to have that dental history repeated if it was a successful outcome. Finally, the social history. Are there other siblings in the household that have similar conditions? And if there are other conditions, then one of these patients may be treated, the one that comes in for all the examination, but other patients who are there and siblings of the child who is receiving care might be experiencing the same sort of things. Has there been any social history of abuse to the child? Has there been any dental neglect that's occurring with the child? Is it important, the relationship between the children and the other siblings, that will make a difference in terms of how this patient is perceived? All of these elements are important for your pre-anesthetic patient assessment that will help you to design a treatment plan that allows the patient to receive optimal care under optimal conditions. The pre-anesthetic patient assessment, and number 2, is allergies review. And what we mean by that is the patient taking any medication. Do they have allergies to food? Do they have allergies to medication? It's essential to know what these allergies might be. Asthma is one aspect of the allergies. That's really important to do that and understand how allergies are affecting this child. Anesthesia history. Have they been taken at the hospital before? What was the outcome of this treatment in the hospital? Was it essential that the patient receive specific types of drugs that are utilized, some that they may be allergic to, some that are acceptable for this patient? So understanding the anesthesia history and what the outcomes were of that is a very important way to determine what the future may hold for this child with another anesthesia for dental care. Is there a family history of anesthesia issues? For example, patients that may have problems with anesthesia, malignant hypothermia would be one of those. Allergies to any of the medications used to anesthetize the patient. Those would be important aspects of knowing the family anesthesia history. Was there any anesthesia problems with parents of these children that come in that may signal to us an area of concern? Current medications and dose, how frequently they take these medications. Patients who may have heart murmurs, for example, may require pre-anesthetic sedation precautions because the patient may have to take these medications to preclude the concerns about the cardiac condition. Medications such as allergies, are those taken? And allergenic medications that are used can combine with sedation medications and increase the level of sedation beyond what you would normally expect. Anesthetic evaluation and the utilization of asthma medications also. The utilization of seizure medications, which are important to take even on the day of general anesthesia. If anything is not understood about the current medications, what they're used for, how they're used, after careful evaluation and research on your own to determine what interaction that might have with a sedation medication, it may be appropriate to send the patient for a medical consultation. If there's anything physiologically that needs to be understood, it needs to be sent to the MD for them to take a look at the child and provide you some information along with your own research to be totally comfortable with what's going on with that child. When was the last meal? Did they have that according to the guidelines that we provide? And that is generally oral liquids that are clear can be taken up to 2 hours prior to the treatment. However, light meals must be delayed at least 8 hours prior to taking the patient to the hospital and putting them under general anesthesia. The last thing, obviously, is the clear liquids, and we don't want to dehydrate the patient before they come in for treatment. It's essential that we know that they've had some clear liquids up to 2 hours before. They can continue to have clear liquids, but nothing with any pulp in it, no juices that have pulp within it, and certainly not any cow's milk for children that are still lactating. Extraoral examination, it's really important that it consists of an evaluation of the patient's physiognomy. What do they look like? What is the gait? Do they have a limp when they come in? Are they symmetrically disposed? What about the limbs, the arms, the legs? Do they function properly? Are they the same size? What is really going on with this child to get an idea of what their health might be? Their eyes, is there any disparity in the symmetry of the eyes as those are observed? Is there any dilation of the eyes? Is there any meiosis that's occurring? Ears, do they have any hearing aids? Are they disabled in their auditory discrimination? Do they fully understand what is being said and how it's being said? The nose, is there any difficulties with that? Is there any obstructions? Is there any difficulty in breathing through the nose? Is the patient a mouth breather? The apparent mental status of the patient. Are they taking any medications for ADHD or ADD or any behavioral concerns? Are they the average child for that age and development? Or are they patients that may have some disabilities which need to be taken into consideration? What is their social demeanor? Do they get along well with their siblings? Do they get along with their schoolmates? Do they play well with others? Do they prefer to play independently? All of these factors must be determined to help you with the management of this child prior to their sedation. So what about the appearance of the face? Is it symmetry of the eyes? Are they hypoteluric, or are they much closer together? What's the distance apart? Are they aligned at the same level? Is the face symmetrical? Is there any hemifacial microsomia, for example? What is the iris color? Are they different? Are they the same color? If there is any. How is the patient walking? Do they limbs? Are they evenly balanced? Are they unaided? Are they being carried? Are they able to bend and reach and have the average mobility for their age? The limbs, are they bilateral? Are they sized appropriately? Is there any limbs that were not developed properly and may be stunted in their development? Are they flexible and mobile? Do they have any arthritis? Are they able to oppose their thumb and fingers? Do they have thumb and finger habits present? All of these things are essential to designing and developing a full-fledged treatment plan that will answer all of these issues for the child. The eyes, are they clearly focused? Do they follow individuals present easily? Do they establish eye contact? Do they not establish eye contact? All of these factors are important. The nose, is it clear? No secretions? The mouth is closed for easy breathing. Is the patient a mouth breather? And if so, there's going to be some dryness on the dentition that's going to contribute to the continued development of early childhood caries. The extraoral examination is a chance to evaluate the mental status of the patient. Are they responsive for their age? Can they answer specific questions? Is it possible that they do not understand what is being said or do not comprehend even though they have good receptive language skills? Are they shy? We know that shy children are very difficult to manage because they often have dental fears and anxieties. Or are they outgoing And outgoing allows them to be sociable and allows them to have interface with adults, strangers, that make it a little easier for them to accept the types of care that we are entitled to deliver. Do they cling to the caretaker? Do they come in before the caretaker? Is a 4-year-old being carried when normally we expect 4-year-olds to be walking? So all of these clues help us to evaluate what's going on with the patient. Are they talkative and appropriate language skills for their age? Do they have good language skills? Some of them have great language skills at 4, and oftentimes it's because they have some more adult caretakers that help. Grandparents, for example, who treat the child more maturely than often the parents do, and it allows them to be much more conversive and be able to understand higher levels of social interaction. What is the social demeanor? Are they friendly? Are they shy? Do they establish eye contact? Do they shake hands easily? And knowing that children, when you hold your hand out to them, if they will reach out to you and establish physical contact, it's an opportunity to see how they socially adept they are, but also that they do not fear what's going on with you because they do not know you. And if you just hold out your hand and see if they will take it easily or not, then it will help give you a clue as to whether this patient is approachable. This palpation of lymph nodes of the head and neck, easily for cancer screening, that's important to do that. And also as you're looking intraorally, we'll talk about that in a little bit, to do an examination for cancer as well. Breathing, is it average for age? Is the rate average for age, or is it faster? Is it slower? Is the patient very active, or is the patient very relaxed? Heart rhythm, rate, is it appropriate for age? And of course, during the extraoral examination, it's good to auscultate both the lung, the passages, to understand what is going on. You may hear some noises or inspirational stridor, for example. And for cardiac, you want to know the rate and the rhythm that's going, and is it appropriate for that age? Do you hear any clicks or pops when you're listening to the heart? And if there's any question that you do not feel comfortable with the cardiovascular respiratory system, it's time to send them to an MD and get an opinion as to their health to undergo anesthesia sedation that we're talking about. Intraoral examination is a time and a place where we are most familiar, and that's the appropriate teeth for age and development. Do they have all of them? Have some of them been lost prematurely? What was the reason that they were lost prematurely? What was the reason that we may have delayed development? And oftentimes there may be extra teeth, and looking and taking radiographs to help us do an intraoral examination is really important. In addition, looking at the occlusion, it's important to establish what the primary molar relationships are, what the terminal plane relationship is, what the canine relationship is, what is the overjet and overbite. We know that there are certain guidelines for us to take a look and see if there's crowding. Do they need to have future treatment for orthodontic reasons, for crowding, excessive crowding, or do they have a greater amount of space? Is there a crossbite developed? So these are important aspects to record when you're doing an intraoral exam for a complete examination. Overjet and overbite should fall within certain parameters, and if they exceed or do not exceed and are understated, then it's important to know exactly. Are crossbites evident? The soft and hard tissues, are they in good shape? Is there lots of caries going on? Is there some gingivitis occurring in this patient? The primary molar terminal planes were noted, and when you put those on, it's really a predictor of what's going to happen to that child in the future. And so if you understand the terminal plane relationships and the primary canine relationships, you will be able to predict for the family what is going to happen with that child. It is a clue also to find out if the parents have had orthodontic treatment or had any teeth, permanent or primary teeth, removed, to make sure that their teeth are aligned up properly. And if you see any of that, that's the value of doing the intraoral examination, because you will be able to predict that oftentimes the children will follow the same pathway the parents had. What is the chief complaint? This is very important. So why was the child brought to the dentist that day? Why not another day? What was the motivation for them to bring that child in? Oftentimes it's caries. And also, sometimes it's because they couldn't afford it. So looking at these issues, what is the motivation to bring the child in that day? Sometimes it's associated with discomfort. Other times it's associated with the parent's perception that it's important to establish some treatment. We know from our own studies in science that we like to see the child within 6 months of the eruption of the first tooth. And if that's the reason that the patient is being brought into you, that's fine. Usually it means we will be seeing a child at 12 months of age and then follow up with recalls that are appropriate based upon the caries risk level and also the history of the risk level of the parents. We know if the parents have had some difficulties with their own dentition, that the child is likely to follow suit. And it helps us to establish a risk level that tells us when we should do recare on these patients. Any pain? Is there any fever or signs of illness? Often parents will come in with, oh, I think I see an abscess on my child's tooth, or I see a dark hole on my child's tooth, or my child has been complaining of discomfort when they eat something, but when they stop eating, it goes away. Then there are those patients that complain of discomfort when they're eating, but also just in the evening when things have calmed down, they're sitting around maybe watching some TV or playing some video games, then they start having some spontaneous pain. And that directs us to those teeth that are critically decayed, and it's important for us to discover what that is so we know how to approach and establish priority levels for the types of treatment we do. The caries are noted and they're severe, or are they moderate, or is it just mild, or is it the parent is overly concerned? Is there discoloration? Does that come from caries, or does it come from something that the child may have been eating? What is the position of the teeth? What is the arch alignment? Is there generalized spacing? Is there primate spaces available? And finally, is there leeway spaces available? All important things to consider as we're looking for the condition intraorally. What's the caries risk level? We know we can establish that by looking at the early caries rate, but also getting some history on mom in terms of what the diet has been, what sort of dietary habits they have, as well as oral hygiene habits. And it establishes a risk level that allows us to provide some opportunities for the child to come in and receive some care. Are there signs of a malocclusion? Is there crowding in the primary dentition? Is there missing teeth in the primary dentition, either caused by early tooth extraction or by simply malalignment of the teeth? And if so, we need to develop a plan that will allow them to receive care, to have good arch alignment, and look into the future and provide some advice regarding orthodontic care if the child needs it or perhaps doesn't need it. Finally, intraoral exams, soft tissue. Do the soft tissues look great? We used to think that gingivitis did not develop in children. We do know that it does occur in children early on, and it's really important to identify oral hygiene habits that affect the condition of the soft tissue. For example, gingivitis may be present in a 3-year-old, and it may be due to oral hygiene, it may be due to prolonged bottle use, it may be due to the fact they don't brush very well. Oftentimes parents come in and they will tell you who is brushing the teeth. It's a 3-year-old, and typically you'll hear say, they'll turn to the child and say, see, I told you that you should have been doing a better job brushing your teeth. And that's a clue to you that this child at 3 years of age doesn't have fine motor skills, and it's really important to know that the parents have neglected brushing these child's teeth just out of lack of knowledge. So it's time for us to provide the information that they need to do the cleaning of the dentition until the child develops fine motor skills, and that's identified by looking at, can they tie their shoes, can they color within lines, can they write their name in cursive in school. And if they do have those fine motor skills, then at that point they should have been trained up to that point, usually 6 or 7 when that occurs, and they can then take care of their teeth themselves along with flossing. And so it's important to understand the roles that parents have and the guidance that we can provide to them to help them furnish for their children the skills that are necessary to be able to take over the job of brushing the teeth. What does the hard tissue look like? Are they eroded? Is there signs of grinding, tooth grinding? And are there signs of tooth malposition in the hard tissue? And typically we like to make sure that we're doing everything we can to save teeth and preserve arch perimeter so that when the teeth develop and the permanent teeth erupt and take over, that they are well aligned. When looking at the tongue, does it have good color? Does it have good mobility? Can the child move their teeth laterally left and laterally right to see what's going on with their tongue? Does it have good mobility? Does it allow the child to function properly? And it's a time also to look at speech. Is it appropriate? And we can have the child count to 10 for us. Do they know how to say the words? Typically when they get to 6 or 7, that's a number that when you say that, if they substitute TH for S, then it's important for us to determine if they're being evaluated by the school system or recommending speech therapy, or at least getting a consult from a speech therapist, what the aspects of the speech are. Is it a receptive speech difficulty where they don't hear very well and so they're replicating what they don't hear well? Or do they have a tongue or finger habit that has resulted in an anterior open bite and there's no tooth surface on which to phonate and provide the correct information? Is the throat clear? Is there any secretions? Does the patient have any cough? These things are good to look at, particularly if you're considering sedation with the patient. You want to look at the back of the throat and see with your Mallampati score, is it sufficient space if the patient would need intubation? And the Brodsky score, and that is the evaluation of the patient's tonsillar tissue. Are they kissing tonsils, or is there 25% or 50%? And we'll be talking that later on in the course on how to determine what's the appropriate level. The tonsils, are they of average size and color? There's no infections present. Oftentimes you look in the fauces of the tonsillar pillars and see very large tonsils that are impregnated with pussy material, and that tells us that this would not be a very favorable patient to put under sedation. Number one, because they can spread the infection that they have to others that are in and around if it's a bacterial infection, or it also allows us to make sure that the infections are treated with some antibiotics if necessary to make sure that the tonsils don't oppose themselves if you gave the patient some sedation medication and then they tend to relax and the normal tone of the musculature would not hold the tonsils apart. So it's important to come up with an idea of how effective the tonsils are going to be. The medical history is the preeminent aspect of evaluation. When we do our intraoral examination, we want to know that there's a relevant review of systems, and any abnormality that's noted is discussed with the caretaker, especially cardiovascular and respiratory systems, allergies, liver, kidney or neurological illnesses, bleeding issues. Is the patient taking medications for any condition? What's the family history of hospitalization? Is there any history of early death of the immediate family member before age 50? And all of these features, review of systems and condition of the family that brings the child in, allows us to assess what might be genetically influenced from the parents, but also might be a congenital issue that has developed with this child particularly, or something that's been environmentally influenced. For example, living in the home with lots of smokers, and it tends to affect asthmatic kids severely. So those are the types of things that we want to ask the follow-up questions when we get the medical history. What's going on? How did it work out? Is there something that can be done to make sure that the patient is as healthy as possible, and even getting MD consultations to help us assess what's going on with that child. It's imperative that we know, however, what drugs are being taken by the child, what allergies they might have, do they have any bleeding issues, and this all comes through a very thorough and focused medical history. The dental history, previous dental visits, and outcomes, and history of hospitalization or sedations for dental reasons. These are important things to assess because it's important to know why the patient came to you if they were receiving care elsewhere. Is it a case of recidivism where the repeating of continuous tooth decay occurring on the child even after they've been repaired fully at one time? That gives us a clue as to the success rates of the patients, and are they going to be successful after the treatments that we do. Does the patient take any fluorides? And if so, what fluorides are they taking? When are they taking them? How much are they taking? Does the patient have well water? Do they have municipal water? Is the municipal water fluoridated? Are they drinking bottled water? And these days we do not know what the fluoride content of water is if it's bottled. And generally it comes from multiple sources. So having one particular location where they get water is not guaranteed when we have children that are seeking water supply. Who brushes the child's teeth? Is it the parent that's doing that? Is it age appropriate? Is the child 9, 10, and the parent is still brushing the child's teeth, and a child who is not disabled? Or is it the child that is responsible for brushing their teeth at age 2 or 3? So it's important to know exactly what that is, and that will give us a clue as to the future improvement in oral hygiene and who might be able to deliver that. How many children are there in the family? It's important to know that socially, because oftentimes parents have multiple children and barely have enough time to take care of one, and they have 9 or 10 children in the family. And the dentist may order dental x-rays for a complete diagnosis of the condition. We will know as we look at children whether they have dental conditions that are going to require us to take dental x-rays. And it's important to get a look intraproximally. Even after a thorough oral exam, in many cases we cannot see intraproximally with the children, and there can be some clandestine tooth decay developing. That's the reason that we take x-rays. It's important for parents to understand that, since there's some aversion to taking x-rays excessively, and make sure that we at least have sufficient information if we are considering sedation and hospitalization, so that we take care of all of the teeth that require care before we decide to see the patient again. So it's important to get those dental x-rays, make sure we know what the progress is going to be. Finally, social history. Are there any siblings? And what do the siblings' oral hygiene look like? And get an assessment from the parents. How are the others doing? Do they have the same kind of conditions? Oftentimes you'll see that older siblings don't have any conditions like this, and that the upbringing of the child that is presented for care has been a little bit different. Or it could be a blended family, and when there's a blended family, there are different methods of oral hygiene care that have been instituted, and it's really difficult to have a consistent one when we learn of these blended families that have differences in philosophy of taking care of their teeth. Have they had any significant medical or dental history? Do you have similar conditions to the patient? Are the siblings from the same mother or father? Do they take any medications that is similar to the patient? Is it medication, for example, a family that might have autism? And I've treated families that have multiple autistic kids in the family, and are they treated the same? And is the spectrum of autism severe or mild, and is it the same for all members of their children? So it's important to know who is doing what and whether you can improve the situation of those families by taking care of their oral health. If a medical history consultation is needed, are there dental consultations to other specialists that need to be reviewed? For example, if they have congenital heart condition, they have been early on to see a pediatric cardiologist, and when they determine that there are significant features of the cardiac condition that need to be monitored on a regular basis, then you need to find that out for not only the patient you're treating, but also for the other siblings in the family. And it tells you how busy a parent might be in terms of managing their own household with other children who might have medical conditions that need to be taken care of. And depending upon the severity, they may be totally focused on this child that's older or younger because of their medical condition, and it takes much of the time that that parent could devote to the child of note that we're looking at. Why was the consultation sent? Be sure to annotate on there what your plan is. If you're going to sedate or give the patient general anesthesia, this is what you plan to do. These are the medications you expect to use. Would it be safe for the child to have these medications, or would it not be safe for the child? And the pharmacodynamics and pharmacokinetics of each drug that you provide for your child must be known so that you know how to blend those drugs together or separately to be able to provide the outcomes that you want. Make sure that as the patient gets closer to the sedation, that you ensure that the parent understands what NPO, it's nil per os, is what NPO means, nothing by mouth. And we want that status observed by the parents when the child comes in for the expected sedation and the last time they had clear liquids, to remember how hydrated the child is until that time that they come in. If your case is a long case, you need to be concerned about hydration and the hydration that the patient comes in with, but also ensuring that a good IV is started with the patient or an IO to ensure that the patient is well hydrated during the procedure so that we do not have a recovery period that's addressing hydration that should have been addressed earlier. And are there any questions regarding the expected procedures for the child? This is a very important aspect of the care in the social history. What is the parent expecting? And we certainly want to meet and exceed those expectations for the child. And if we know what was expected before they came to your office, if they had gone to another clinician, and to understand what the expectations of the parents are. Sometimes the expectations are unrealistic. Sometimes they are realistic. Sometimes they are misunderstood and well below the mark of where we expect to be. So these are important features to be able to find out during the social history gathering. Level 1 sedation, as we talked about a little bit earlier, is the patient evaluation. Is the patient a 1 or 2? And that's the level at which we are going to be talking about moderate sedation. And it may consist of a review of their current medical history and medication use. And patients with significant medical considerations, ASA 3 or 4, may require consultation with their primary care physician or a consulting medical specialist. So really it's important to state that again, the patient's ASA 3 or 4, it's important to require consultation with their primary care provider or physician or consulting with a medical specialist for the particular care of that child who's about to undergo level 1 sedation. Pre-procedure preparation and informed consent is really important. The medical history, drug allergies, serious illnesses, current medications, previous hospitalizations, and significant surgery, a review of its physiologic systems identified by patient history, baseline vitals, blood pressure, pulse, not required for children under 12 in the state of Texas. However, it's important if you feel it needs to be taken. You don't need to have a rule to guide you to taking that. Be sure you get it if you're going to take a patient to the hospital, unless the medical history is indicated. And informed consent. And a BARN is an acronym that's used to describe the things that have to be discussed with the parent in terms of consent, and that's benefits, alternatives, risks, or no treatment. And that BARN acronym helps to remember which things we need to talk to the patient about. The personnel, and equipment requirements available to take care of this child is the doctor or DDS or DMD and the BLS trained personnel that are there to assist. The patients need to be a fail-safe check on the nitrous oxide unit and have an oxygen analyzer with alarm, scavenger system for other gases, and monitoring dentist remains in the operatory until the discharge to recovery. And this is an important aspect of it, that our rules tell us that we need to be in that room with that sedated patient until the patient is ready to be recovered. And we need to have standards to which we are looking. Is the patient awake and alert? Are they conversational? Can they reply appropriately? Do their eyes look like they have returned to normal? The meiosis has resolved? And to see exactly where the patient is, because we must remain with that patient as long as the patient is feeling the effects of sedation. Monitoring that's required. In the state of Texas, we have some alternatives, and one is the pulse oximeter, and that's something that we use, but also capnography. Capnography, when we go to level 3 sedation, is important for us to determine the ventilation assessments of the child as they're undergoing the treatment. The chest excursions, are they shallow? Are they deep? The blood pressure and pulse, the pre and post-op and intra-operatively as indicated, these need to be monitored on a regular basis. And because we're doing level 3 sedation, it's important for us to have a third person with us who can record what is going on with the patient. So this requirement is really a safety measure to be ensuring that when medications are given, and also it's handy to have somebody there that should a misadventure occur, that we would have somebody there to record the information and the medications that will be delivered in a recovery situation. Documentation, the names and dose of drugs that are used when the patient is receiving their sedation, the time-oriented sedation record, registration at appropriate intervals of no more than 10 minutes. So at least every 10 minutes some documentation of the vital signs needs to be made. That's something that we need to have that third person available for to be able to do that. Recovery and discharge. There's oxygen in the recovery area. We need to ensure that that's there. The doctor must monitor the patient until they're ready for discharge, and then they can delegate that to a qualified assistant. The dentist must qualify the patient for discharge according to objective criteria to the accompanying adult with postoperative information, both verbal and written. And it's nice to have in the recovery period, if a parent is driving home, that they have another adult individual with them to monitor the patient so that no untoward events occur after the discharge to going home. The pre-anesthetic patient assessment and evaluation of pediatric patients. One of the key issues here is the American Academy of Pediatric Dentistry, AAPD, recognizes that dental care is medically necessary for the purpose of preventing and eliminating oral facial disease, infection, and pain, restoring the form and function of the dentition, and correcting facial disfiguration or dysfunction. And it's important to realize that we as primary care providers have the ability to take care of patients as the primary doctor, and that medical necessity is developed according to this information from the AAPD. So it's really important that when we are asked by insurance companies to establish medical necessity, this is a good definition for us to be able to send forward to them. The objectives are non-pharmacological and pharmacological techniques used to alleviate anxiety, nurture a positive dental attitude, and perform quality oral health care safely and efficiently for infants, children, adolescents, and persons with special health care needs. Secondly, selection of techniques must be tailored to the needs of the patient and the needs of the individual patient and the skills of the practitioner. This means that there's not a cookie-cutter approach. There's not a recipe for doing every child the same way. We need to individualize it for that particular patient and ensure that the skills of the practitioner are able to deliver the care according to the outcomes we expect. Pre-anesthetic assessment and evaluation for pediatric patients is a method to allow us to select techniques tailored to the needs of the patient and the individual patient. The patient history and evaluation. What are our objectives? To understand the significance of various medical histories, utilize the information gathered to minimize risk, and to establish treatment planning for successful outcomes. Moderate sedation or level 3 sedation for children, the patients respond purposefully to verbal or light stimulations. Responses are age-appropriate for behavior and are expected. Reflex withdrawal is normal, is not the only purposeful expected response. A verbal communication to the patient would be an appropriate response for a patient who's sedated in level 3, and that there would be a purposeful expected response from that. No interventions are required to maintain patent airway, and cardiovascular function is usually maintained. Deep sedation, on the other hand, is a level 4 sedation, and patients cannot be easily aroused with repeated stimulations. It's important for us to be ready to handle patients who slip from the level 3 to the level 4 sedation, and to be able to care for them until we have additional professional help arrive. The ability to maintain independent ventilatory function may be impaired in deep sedation cases and may require assistance. Cardiovascular function is usually maintained, and reflex withdrawal from a painful stimulus may occur but may not be purposeful nor higher functioning. So if our patients slip into a level 4 sedation, it's really important that we cease doing what we're doing and begin to think about keeping this patient continually functioning and assisting their vital reflexes. And we must be trained to be able to deliver that. The AAPD sedation guidelines is the patient selection, minimal risk, and healthy ASA1 or ASA2, which are controlled asthmas, for example, or controlled diabetics, and have some medical condition but it's not debilitating. So ASA1 are healthy children, ASA2 are children that have some associated medical condition that is well controlled. Responsible parent to accompany the patient and stay at the facility, and insist that they stay at the facility during the entire sedation episode. And the reason for this is in case some untoward event or some special permission is needed, we'll have the patient there and the patient's parent to be able to consent for us to move on to additional treatments. Adherence to dietary restrictions, and we check this before we do the sedation. Have they followed the NPO status? If they have not, then this patient needs to be rescheduled. The absence of acute systemic illness, perhaps when you evaluated the patient, nothing was going on, but then they may have a severe respiratory infection, and it's those patients with enlarged tonsils and perhaps accompanying obesity would not be desirable to treat those patients at that time. The patient has a clear patent airway with minimal obstruction by the tonsils, and this is the value of our intraoral examination to determine the obstructive potential of the tonsils and ensure that they have a patent clear airway. If they have enlarged tonsils, are getting over an infection, it's best to postpone the sedation episode for that treatment and to prepare the patient that this may occur so that the patient doesn't come in with an infection in their tonsils and expect us to go ahead. Let them know clearly at the very beginning in the pre-sedation evaluation that if any of this should occur, the patient will not be treated. Finally, the health history review and the medications. We want to know, are they taking any medications at the time? If so, what is the type? Is it an antihistamine? Is it an opioid? Is it an antibiotic? It's important to know what type it is. And then how much dosage? Are they taking it 3 times a day? Are they taking it 4 times a day? How often have they been taking it? Do they take it regularly? Have they skipped any of their dosages that they are required to take? What is the frequency of it? Does this happen periodically, monthly, every 3 months, every half year, every year? Seasonal allergies that come on board and medications being taken. So all of those things need to be determined, the dosage and the frequency. What is the timing? Do they take it 3 times a day? Is it a liquid? Is it a pill? Is it an injection? If they're diabetics, for example, then they require insulin injections. How well are they controlling that? Are they controlling their diabetes really well? Or is it simply a matter of watching the diet? What is the route? Are anti-seizure medications, for example, may be taken with a sip of clear water prior to sedations. And that's really important to know because we know they're supposed to be NPO and clear liquids only up to 2 hours before, but if they have to take seizure medications and they take it regularly in the morning, it's important that they just take that with a sip of water and be on the alert that you have activated the gastric system, and it's important to ensure that we don't have any repercussions from taking that medication. Are there drug-to-drug or drug-to-herb interactions? Are the patients taking any herbal medications? And often these days, many patients are taking over-the-counter medications that can affect how the sedation drugs operate, the pharmacodynamics of what's happening under those circumstances. And are there any allergies and adverse reactions to any medications that we might be providing for the patient to ensure that they are completely healthy during the sedation episode and make sure it's taking care of it? What about the health history? The number of children ages 12 and younger being administered an over-the-counter medication. I think you'll see by this chart that most commonly over-the-counter medication for children are analgesics and antipyretics, acetaminophen and ibuprofen. And so is there a chance that the child that you are sedating is taking over-the-counter medication? You bet. There's plenty of opportunity for that to occur. Medications that may affect sedation levels are sedative anxiolytics such as Valium, Ativan, Versed, Xanax, antihistamines such as Benadryl, hydroxyzine, promethazine, antidepressants, tricyclic, selective serotonin reuptake inhibitors, anticonvulsants such as Tegretol, Lamictal, Topamax, and Klonopin. These are drugs that will affect the sedation level. If you can't remember these, make sure you have a list of those available and ensure that when you get the patient's history that none of those drugs are on it if you expect to do a sedation for them. Medications taken by the patient is a signal of underlying conditions that may be masked by the medications being taken. Medications may be additive or symbiotic and can increase the effects of the sedation drugs being prescribed. If one does not know the medication, then it is imperative to review the drugs, determine if there's any interaction with the drugs being used for sedation, and if not available prior to sedation, contact the primary physician for approval of the sedation regimen for the child's treatment. In some cases, it may be necessary to discontinue the child's regular medication so as not to interfere with the pharmacokinetics of the drug being used for sedation. Once all systems are reviewed, the patient exam completed, and the treatment plan developed, a frank discussion of the expected outcomes of the treatment is discussed with the parent. Ensure that all questions are being answered about the expected treatment and the recovery instructions. Think about the expected outcomes and all possible results so that parents are fully understanding what to expect, and even if it is the unexpected, let them know who will follow the patient, the possible medications needed for the post-operative treatment, and how long the recovery might be. Consent must be signed that allows treatment, and also the full understanding of the parents and caretaker of the patient and what the outcomes might be. Emergency patients are a different category altogether. If there's been trauma or heart disease or obstructive sleep apnea, decreased level of consciousness, or extreme obesity where the BMI is greater than or equal to 95% for the age and sex, appropriate dosing for overweight or obese children should be based upon ideal body weight or lean body mass. A nomogram has been developed that calculates the lean body mass using a chart. One only needs to know the child's age, height, and the total body weight to be able to use this nomogram. It helps to show if the child's BMI is greater than or equal to 95th percentile for age and sex, and if so, those patients are categorized as obese and not just overweight. Tonsillar size is important to know, and we have the Brodsky scale that helps us to determine exactly what the size is. When we sedate children, their muscles relax, the tone goes away, and tonsils will tend to be much larger than it initially appears upon oral examination. The time of the last meal and the risk versus the benefit of sedation makes it an important decision, the lightest effective sedation to be used. For example, if we were to see a patient on an emergency basis, we want to know when the last meal was, and is it important, is it more important for the benefit of the treatment than it is for the potential about last-minute meals to make a decision regarding should we go ahead with the sedation or not. Oftentimes, emergency room physicians help us with this, and ER patients requiring deep sedation may use ketamine or moderate sedation, which would maintain protective reflexes, and the MD who is administering this for us feels very comfortable with the outcomes, and we can feel comfortable in discussing this with us if we go to the OR frequently for dental trauma or other types of emergency dental care. Patients requiring deep sedation, bowel obstruction, or trauma may need to be intubated to protect the airway. And finally, the use and protective stabilization must avoid airway or chest restrictions, check respiratory excursions, and head position frequently to ensure that airway patency is available. Smaller children require a shoulder roll to keep their head in the sniffing position during treatment, so it's important to ensure that those parameters are met in sedation for patients of emergency patients in that category. So what are some of the questions one might ask as they get ready to complete this course in sedation? Do I have the qualifications to perform sedation or anesthesia? Or do I even want to do sedation or anesthesia? And if you're taking this course, it's quite likely that you do want to continue with sedation and anesthesia. And so the outcomes we hope will be answered is that yes, you have the qualification, and yes, you will take this course and understand it, and perhaps learn how to be more safe with your patients when they come in to see you. When should you contact the patient's care provider prior to sedation? You should do that whenever there's any question about the medical condition of the patient or any medications they're taking or allergies or bleeding issues that they have. If you're unsure about how that patient will respond to the sedation, then you need to send a consultation to the patient's physician to be able to understand fully what the outcomes of that patient will be. And are you ready to provide rescue if sedations change to deeper levels? This is a very essential question you must ask yourself, because if the patient goes to a level deeper than you have expected, you want to be prepared to keep that patient well taken care of before they have deeper problems. And is your staff ready to handle any emergencies? And if you have a staff that helps you with the sedations, it's important that you carry out simulations in your office at least twice a year, or maybe even more frequently depending upon the skills of your assistants. It's important that they know what to do, and must remember that you as the care provider, as the one who is handling these children, it's good to have the PALS training, because you are going to be the leader of the rescue team that's in your office before EMS arrives, and make sure that you are handling the patient appropriately. If you need clarification on any information, send an email to the PACE Center at uthtmc.edu so we can clarify any of the information that we've provided for you today. Listing of the references you will see. This is all the background information that has been provided for you to utilize and to investigate and to learn more about what you're doing. And it's a way for you to ensure that your skills and your didactic knowledge and scientific information is complete so that you can handle these patients safely and that your outcomes are very favorable. This completes this section of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. Due to the nature of our subject content, a passing score of 80% is necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you will be instructed to take the exam and a new set of questions will be provided. You'll have 3 chances to fulfill the requirements. If you're not successful, you will be instructed to review this section again. Good luck on the exam. If you're ready to take the next section upon completion of this exam, you will be provided a link to continue. If you wish to proceed at a later date, you will need to log in and no further payment is necessary since this is a continuum.